and things like that as well. And yes, we are recording this today. So, team, do you think we're ready to get started?
Yep, 12:04.
Okay. Thank you, everyone, for joining us. We do want to first go ahead and look at, Sam, can you advance the slide? It's not working for me.
I don't actually have, let me see.
Oh, there we go. Okay.
Got it? Okay.
So as a part of this, you all received the continuing education requirements. We just want to, again, make sure that everyone understands what the roles of this important part of getting the CEUs. We want everybody to be able to participate. Please, you need to be a part of the entire session in order to be able to get the CEUs. And I think, as I said, you've probably all read this already, so we can move forward. It is, yes, important that you are here at the beginning and at the end. Today's presentation will be recorded, and I think I saw that the recording button has been clicked, right, Sam? Awesome. And if you have a question as we go through this session, we love your questions. Please put your questions in the chat and we'll be able to take a look at them throughout. Some questions we know might actually be a part of the presentation, and other ones we'll certainly address as we move forward, okay?
Also, can you put a Q in front of your questions so that Sam and Aubrey can filter them out? Thank you.
Thank you, Michelle.
Thanks, Michelle.
So today we're talking about the roles of the medical aid and dying team and the requirements of the law, and specifically focusing on the nurse, the social worker, and the hospice teams. We also are introducing our new organization, Hawai'i End of Life Options, and we are excited to have formed this company to be able to continue the work around education and navigation for patients and for professionals. We just continued our connection with Compassion and Choices at the end of June. They had been a part of being here with Medical Aid and Dying for a number of years and had done just a wonderful job in helping get a law developed and passed. And at the end of June, it became time for them to start focusing on other states. And so Aubrey and I and a few other folks started to say, well, now what are we going to do? And so we decided that it was time to put together an organization for Hawaii. So we've done that transition. Our fiscal sponsor is the Hawaii Public Health Institute, which is a wonderful organization to be a part of. And our primary focus, as I mentioned, is around educating and supporting patients and providers and empowering terminally ill individuals with a full range of end-of-life options. Thank you. We have some great presenters today. Susan Amina is a retired APRN from Kaiser. She's got lots of experience with the Kaiser focus around medical aid and dying. We have Michelle Cantillo from Hawaii Pacific Health. She's a nurse focusing on advanced care planning. She also has been my partner in crime in helping to get this whole CEU going. So thank you, Michelle, for all your time. We have Dr. Emma Grote here today from Navi and Hospice, and we're so excited that she can join us and share what medical aid and dying and end-of-life care looks like and links with the patient's needs and the family focus. And I'm Karen Ireland. I have been a part of healthcare organizations in Hawaii for a long time. It's been fun to work with Compassion and Choices, and now as a consultant with Hawaii End of Life Options. And all right, gang, away we go. So our learning outcomes today: describe at least one requirement of the Our Care, Our Choice Act, to be able to describe one of the various provider roles and the importance of team-based care, such as the MD, the APRN, navigator, mental health providers, pharmacists. Describe one communication technique in discussing with the patient, and design and describe one aspect of care around the patient's understanding and support resources in order to navigate and advocate for the care coordination required for Our Care, Our Choice Act. So who's here today? We'd like to know who you are. So if you can put your information in the chat, that would be fabulous. Just let us know what your role is and what organization you might be with, so that we are able to really understand the breadth and depth of the community we have out here. So we need to pull up a poll. We'd like to have a poll that all of you are able to react to. So Sam, can you help pull up the poll? Or Michelle?
Sam, I can launch it. Oh, she got it.
Okay, so friends that have joined us today, can you please go ahead and answer these 4 questions as a part of our process? I just love these new capabilities of Zoom.
We have about half of the participants have participated so far. We're halfway there.
Okay, that's great. Just one more minute maybe to finish up.
Just your best guess.
Remember, it's a pre-test. You have to do 100% in the post-test to show you've listened to us. Okay? So we don't care about the pre-test. You could put the wrong answers, but the post-test, 100%.
There you go.
Sandy, the test should have popped up for you, but if you missed it, that's okay. But it should have popped up on your Zoom. Maybe if it's on your phone, you'll need to scroll over. All right, well, we've had 116 out of 145 people so far.
Wow, that's great. Okay, what do you think? 30 more seconds, Sam?
Sounds good.
All right.
Number 3 is almost 50-50.
Who designed these most excellent questions?
We spent time thinking and asking and hearing what might be good options. So
All right.
thank you. Thank you, everyone, for participating.
All right, can y'all see the results?
All right. Oh. So today's event is meant to be an education about medical aid in dying, including these components. Really focusing on the primary care providers' support, the family and religious factors, the patient's requests, the goals of care with the patient and family, the medical aid in dying prescription process, the hospice enrollment and role, and bereavement support. However, first we want to start with the basics of the law. Susan?
Great, thank you, Karen. So let's start with definitions. What is Our Care, Our Choice Act? This is a Hawaii state law, effective January 1st, 2019, giving eligible adults the option to request a prescription to allow them to die peacefully in their sleep. Medical aid in dying, which is referred to as MAID, is recognized as the medical practice in which a mentally capable adult with a prognosis of 6 months or less to live may request a provider's prescription for medication which they choose to self-ingest. And it's important to note that as of June 1st, 2023, the term provider actually has been expanded to include APRNs, who can be the attending or the consulting provider, and psychiatric APRNs, being the mental health provider, as well as marriage and family therapists. So really nice to be able to hopefully increase access with these additional providers. And next slide. So who's eligible? In Hawaii, you have to be an adult, 18 years or older. You have to be a state resident. Out of the 11 jurisdictions that MAID is actually legal, there's 2 that don't require state residency, just for your information, and that's Oregon and Vermont. And in the law, it states basically what you need to provide in terms of proving that you're a state resident. Terminally ill with a prognosis of 6 months or less, able to make one's own medical decisions, and then able to self-administer, which we'll talk more about in just a bit, the self-administration piece. Okay, next slide. Medical aid in dying is not suicide. So I really like this slide in terms of really comparing the two. You know, in MAID, obviously, there's a terminal diagnosis, not always, typically not the case with suicide. There's mental capacity in medical aid in dying, as indicated by an evaluation. Often with suicide, there may be a psychiatric diagnosis. The key is that the patient wants to live, but is terminal, right? And this is where it's truly tragic, working with these patients. They don't want to die. Whereas in suicide, obviously, there's a wish to die. MAID is often planned versus suicide being impulsive. Death is gentle. Death may be violent. And then often there's normal grieving when the patient passes, right? As opposed to that abnormal grief of what if I hadn't, what if I didn't pick up the signs of this patient being suicidal? It's important to note that the American Association of Suicidology, an organization that's dedicated to the prevention of suicide, does not consider MAID a suicide, right? So national organizations obviously agree with this. Okay, next slide. If we look at the provider components, so in Hawaii, there's 3 providers that need to evaluate the patient. The first one being what we call the attending provider, which again can be a physician or an APRN, and they are the prescriber. They're evaluating the patient. They're ensuring that all the steps are in compliance with the law. They complete the death certificate. So important to note that cause of death is the terminal disease and not medical aid in dying. And then they submit forms to the Department of Health. So know that each of these providers completes a form from Department of Health. They're collated along with a written request that the patient submits, and that needs to be submitted to Department of Health within 30 days of the writing of the prescription. The consulting provider, again, can be a physician or APRN, evaluating the patient, agreeing or disagreeing with the attending provider's assessment. Typically, there's an agreement. And then the mental health provider. And so you see who's listed there. And notice a licensed clinical social worker as opposed to a licensed social worker who can do this evaluation. And I think what's important to note is, right, it's not unusual that these patients are not going to be depressed. They have a terminal disease. They don't want to die. The issue here is that terminal disease interfering with their decision-making to make this decision? And this is a fairly basic evaluation. There's no specific tool that's being used. I can share with you that I know at Kaiser, the psychologist that does a lot of these, uses some tools, but again, no specific tools directly related for medical aid in dying evaluation. Hawaii is the only state who actually requires this. All the other states, again, as I said, there's 11 jurisdictions, including DC, and no other state actually requires this. So one might think that in the future down the road, this evaluation may be deleted. Okay, next slide. So the attending provider's role is really in part to explore the reasons for the patient's request. And we're going to talk a little bit more about what some of those common requests are. Really to determine social support network. What type of support does this patient have in terms of going through the process, picking up on the medication, if they choose to have family or friends with them, just what kind of support is there? And this is really crucial. There's a case where I worked with a patient who was rather complicated in this manner, in that the wife necessarily didn't agree with the husband's decision, but would be there to support him. There were 2 children, 2 daughters. One did not support the decision. There was some extended family that didn't support the decision. So it gets rather tricky and complicated when you're looking at who's involved with a family. Provider does a medical review of the chart, and in part looking at, will this patient make the 5-day waiting period? And we'll talk a bit about that, but there needs to be a 5-day waiting period unless that provider feels that it can be waived, that the patient's not going to make that 5-day waiting period. Also, is there any potential physical barriers to self-administration? And what I have seen is cases such as those with ALS, Parkinson's, head and neck cancers. They really struggle in terms of when to take the medication because those diseases progress and to progress to the point where they may not be able to actually self-administer. And then also looking at what we call is in the medical review is looking at red flags. So what red flags are does the patient have anything in their history that might put them toward a prolonged death? So for example, are there GI absorption issues? Is there a history of high opioid use? That's something also that's looked at by the attending provider. Evaluations are done in person or by telehealth. Telehealth is allowed. I know at Kaiser, Dr. Miller, who does a lot of the evaluations, actually has a preference to in-person and will fly to the neighbor islands to do in-person evaluations. And then what's important, of course, is reviewing all of end-of-life options with the patient, not just medical aid in dying, but all of the various options which Dr. Grote will talk to. And I think it's important to know that Hawaii end-of-life options is not encouraging MAID, is not promoting MAID. What we're doing is saying, hey, everyone needs to be aware of all of the options, and MAID is only one of them. So next slide, please. Just in continuing, I think it's really important that medical aid in dying is patient-driven. At any point in the process, the patient can recant. They can decide, I don't want to continue, whether they've picked up a prescription or not. The patient decides who they want present at self-administration. It is not required that they have a physician or an APRN or a nurse. It's totally up to the patient in terms of who's present, when they want to take this. In terms of the setting, I mean, the law does prohibit this to be done in a public. It cannot be done in a public setting. Hospitals, to my knowledge, have policies in place that this cannot be done in a hospitalized setting, and some care homes as well. But for the most part, right, this is the patient's decision that needs to be respected. We strongly recommend, but not required, that they're enrolled in hospice, right, for that additional support and the great care that the hospices provide for end-of-life care. And then healthcare professional cannot administer the medication. So let me just read for you in Hawaii laws, the definition of self-administration. So I quote, an individual performing an affirmative, conscious, voluntary act to take into the individual's body prescription medication to end the qualified patient's life. Okay, so it has to be very intentional that this is an act of the patient. Okay, next slide. So patient request requirements, it's required that they submit 2 oral requests to the attending provider, separated by a minimum of 5 days. And what's important is that this verbal request must be documented in the medical record. And we would, really, we've seen patients in cases where they're submitting the request so late that they actually pass away before they can actually have the opportunity to do a medical aid in dying. So the earlier the better within that obviously 6-month time frame. The waiting period, as I said, can be waived by the attending provider if they feel that death is imminent and that patient's not going to survive the 5 days. There is a written request. It's a form, again, from DOH that the patient actually completes and signed by 2 witnesses, one of whom must be unrelated to the patient. Patient's healthcare team cannot be a witness. And then the witness is attesting only to the patient's sound of mind to the best of their ability, acting voluntarily and not being coerced to sign the request. Okay, so there's a lot of questions come up from witnesses in terms of what does it mean when I'm signing this form. And next slide. So mental health evaluation, again, in Hawaii, all patients who request medical aid in dying must be referred to an attending provider, referred by the attending provider for counseling. Those providers are listed. It's really the accountability of the attending provider to make sure that they're referring to the correct health provider that's authorized to actually do this evaluation. And again, the patient, is it capable and does appear to be suffering from under-treatment or non-treatment of depression or other conditions which interfere with the patient's ability to make an informed decision? What other states have found is that this can be done by the attending provider, and there has been no issues around this. But again, for Hawaii, currently, this is a requirement of the law. Next slide. And I think this slide, I'm going to, Dr. Grote, I believe is going to start, and then I may just key in some comments here. Dr. Grote?
Absolutely. So the medications that we use for medical aid in dying, it's a set number of medications, and the medications work to depress the respiratory system and affect the conductivity of the heart, so that patients usually will pass away from complications of respiratory depression and their heart no longer beating effectively. The pharmacists play a key role in education and support. Kaiser, in their system, has a pharmacist which will go over the medications and the instructions to the caregiver or the patient. And here on Oahu, we have one other pharmacy that is willing to compound those prescriptions for us. About 12 hours prior to ingestions, patients will stop taking the medications, except those that they're using to keep symptoms well managed. And for about 4 to 6 hours prior to ingestion, they don't eat any heavy meals, no dairy. We want to make sure that an hour before patients ingest the medication, they take meds to ensure that they don't vomit. And then with the ingestion, you can see there the different medications that we use. And as patients take these medications, we encourage them to do it within three minutes or so, because after that time, they start to take effect, and that can make it difficult for a patient to finish swallowing the medications. They're mixed with about 3 to 4 ounces of fluid, so it's a fairly small amount of liquid, but it's rather bitter tasting, and if someone already has issues with nausea, can be a struggle sometimes to get down effectively.
Great. And what we have found is after patients actually drink it, using like a popsicle or sorbet just to really help to soothe it, it can be rather burning for some patients. So there's some tricks in terms of, making this as comfortable as possible for patients. Since 2019, actually, there's been a couple different versions of this mixture. And most recently, it was phenobarbital that was added, and that really seems to decrease the time to death, which is often helpful in terms of, patients, family they're observing this process. Okay, next slide. Thank you, Dr. Grove. The process, so I think it's really important that there's a lot of patients who pick this up and never take it. But, it's really palliative in the sense that what I've seen is patients get really, there's really some relief in that the fact that they know they have something in case they decide to take it. The patients will say to me, if the pain is so terrible, I'm not going to take this only if the patient's so terrible and it can't be managed. And, I still want to be cognizant and communicating with my family. So it's really a relief in many ways, just having the prescription. In terms of the cost, I can say at Kaiser, the copay is anywhere from 0 to about 270. Michelle, can you share HPH
So
cost?
the pharmacy that we do utilize is Elex RX. It's a compounding pharmacy in Kailua. Even for our outer island patients, they will FedEx to it. In terms of the cost, I know, for example, if it's a HMSA patient, the patient that specifically has to make the payment themselves with the pharmacy. And then basically there's paperwork for the insurance for them, patient and or family, to get the reimbursal if so. Medicaid patients are kind of waived, so there's a process for Medicaid patients. So, but the average cost of the DD MAPH is $550 as of recently.
Great, thank you. And then medication safety, obviously these meds need to be kept in a safe location, typically cool and dry, but obviously away from anyone that can get their hands on this and inadvertently use this. So self-administration, a lot of times orally, especially like with head and neck patients, head and neck cancer patients, we actually recommend that they practice swallowing, like with a thicker liquid like Ensure, just to make sure that they can drink it within a couple minutes. It can be given rectally and through a GT tube or an NG tube. The key there, right, is rectally and GT tube. Patient has to push that syringe. That can't be done by someone else. And then what to expect, typically what we see is patients fall asleep very quickly, within 5 to 10 minutes, go into a deep coma. Most patients, the majority of patients, are dying in less than 2 hours with the addition of phenobarbital. There was actually a large study, it was in the Journal of Palliative Medicine in December 2024, that looked at over 3,000 patients. And about 78.5% died in less than 2 hours. And then about 15% between 2 hours and less than 5. So kind of the standard thought is, quote, what's acceptable is a death that's under 5 hours. And so obviously the majority of those are with this preparation. Know that younger patients, typically it takes longer for them to die. Part of it, right, is just the robust cardiovascular respiratory system. But typically, what we see, right, is kind of the faster, the quicker, the less time to death is just easier too in terms of the patients and the patient's family overall in terms of being there at the bedside with them. Okay, next slide.
Thank you so much for going through those basics. And so we want to ask the question, why are patients asking about medical aid in dying? Susan?
Yeah, so what we've seen is, of course, it's a totality of many reasons at the end of life, but often what kind of teases out is the fear of pain and suffering. And as I say, a lot of patients have said to me, I'm not going to take it unless it's just unbearable and it's just horrible. Loss of autonomy or control at the end of life, loss of dignity, and then just an overall diminished quality of life. And as I say, it really, it's heartbreaking. Especially I've worked with quite a few younger individuals with cancer, that again, they don't want to die, but this is what they're facing, and these are their concerns at the end of life. Next slide. So the roles and responsibility of the navigator, whether that navigator is a nurse, social worker, in the neighbor islands in Hawaii, where there aren't a lot of necessarily support staff, that could be a physician or an APRN. And this is kind of an overview of kind of what this looks like. So the first interaction, a lot of that is just talking in terms of what's the patient thinking about? Why are they thinking about this? What are some of their goals for the rest of the time they may have? What are their fears? What are their wishes? Really trying to understand what they're thinking, and is this the best option for them? Are they aware of all the other options? Setting up the appointments. So typically the navigator is setting up all those attending, consultant, mental health provider. I know at Kaiser, they're the ones that actually help to collate the forms as well as the written request. Documentation, it's helpful to have like a template just for efficiency, as well as making sure that you're meeting all the requirements of the law in terms of documentation for the navigator, as well as for all those providers. Materials for patient and families. Kaiser has a really nice guidebook that we give to families, help them through the process, and kind of as a checklist in terms of what the next steps are. I mean, obviously this can be very overwhelming, being that, a loved one is terminal, and yet dealing with this whole process. I know at Kaiser, there is some telephone follow-up after the patient picks up the prescription, just checking in, questions. Really important that the navigator can be easily accessible in terms of being able to support the patient and the family, and being able to answer questions. And then overall, right, navigator is to be objective, compassionate, and non-judgmental, really kind of value neutral in this whole process. Dr. Grote is going to talk and do a case study around the hospice, medical aid in dying, and then Michelle will talk about an outpatient study, and we'll incorporate some of the roles and responsibilities of the navigator as well. So I think, Michelle, do you want to start with this one?
So very much, thanks, Susan. Very much, very similar to what KP has done. Today, honestly, some people are getting the referrals from patients on my chart. So navigating that path and making sure that the providers do receive it. For us at HPH, once that is in place, word gets out. Mostly the oncology, 72%, I'll show you some data later, are from oncology patients. And for those, our oncology social workers are fantastic. Kudos to them and the nurse navigators. But they'll start that whole process that Susan is there, and then reach out to the doctors. Sometimes the patients, honestly, sometimes they're like, I'm kind of scared to talk to my doctor about this. Can you ask for me? So we'll do that part as well, right? But sometimes, honestly, I say to the patient, you know what? It's good for you to also speak to your doctor to know the request is from you, and then they'll think about it. For us, if a doctor's never participated, my job is really to kind of educate the process and make sure it goes smoothly. So education, it can start from the inpatient, the patients in the hospital, going to getting discharged. We don't start into the process, and I'll talk about that a little bit later. But once it's out, it's all outpatient based. So the anxiety for patients is really the waiting game. So trying to get to that referral early and trying to get those providers to say, hey, I'm willing to accept. Sometimes that's the hardest part for patients. Once we have accepting providers, then we just connect the dots and then provide that sense of, okay, let's just get this process going. I think Susan already went through the waiting period and then the barriers. We've had 2 patients that had did the rectal administration. Again, oncology patients, cancer diagnosis, nauseated, vomiting, throwing up in the last, couple months. And actually, the hospice does not supply for the ones that we utilize, the enema, the rectal, etc. So the patients did have to seek and get that ahead. One of our end of life doulas has a supply now, so thank you for that. Because sometimes we're rushing to get things, and it's like, where are we going to get it? Go to the medical supply store, and it's not available. So all these things we kind of have to assess. Thank you. Next slide.
So
So
navigator
go
role.
ahead.
Yeah,
Go
Michelle,
ahead.
go ahead.
No, it's basically the goals of care kind of questions. The social workers really look at the psychosocial, who's there, who's their support. I don't want our patients to be going through this alone. I mean, Susan, thank you for sharing the difference between medical aid and dying and suicide. We want this to be a team, and the team is the patient's family and where are their support systems. So really have, who do you trust? And not let's be sick, not everybody's comfortable, but who within your support systems are comfortable? And look through all the different options. Did we get palliative care? Please, our patients at HPH, I tell them not mandatory to do hospice, but guess what? Please do hospice, because to do the pronouncement, and I have Emma and her staff, the other hospices, we've worked with all the hospices, and I can't tell you how amazing they are for our patients, and that's what I stress to them. We went through the review process again. This is just repetitive, basically making sure timelines, making sure everything is done, getting the written request in, reaching out. Like yesterday, I made a call to a PCP who's a part of HPH, but we were at a consultant. I said, hey, are you comfortable? Have you done this? I did it 1 or 2. Tell me what's going on now. So it's like, oh yeah, Department of Health has the forms, it's updated, I'm here to support you. Let us know if you have questions, blah, blah, blah. So, and this is the role also for HELO, this, not HELO, but hello, right? This is our role, to be a resources to others, right? Especially those who are unfamiliar with this process. Susan, anything to add?
No, just that Kaiser, they also have a tracking system that is really helpful, that assures that you're meeting the time frame set out by the law. But again, it's a really nice, it's nice for the attending providers, just because this is the first look at this patient by the navigator, and often can give the attending provider heads up on, hey, I think there may be some issues around some family dynamics here, or, I'm not sure they're going to make that 5 days, or I'm concerned about whether they're going to, with disease progression, at what point can they no longer self-administer? So again, this is a first-time look, which is really helpful for the attending providers. Okay, next slide. And so how do you respond to a request for medical aid in dying? And I think, again, Michelle's alluded to this, is basically you're listening, you're asking open-ended questions, really trying to understand what the wishes are, why are they considering this, what their beliefs are, and are they, where are they in terms of the process? Are they eligible at this point, or is it just more for information? Are they in hospice? Again, the team typically is working closely with the hospice in that case. It's using professional integrity. And then if, I know at Kaiser, if you are, let's say, a conscientious objector to medical aid in dying, that at least at Kaiser, they ask staff minimally give them this FAQ. So the patient knows what's the next step, where can they get more information. Certainly no one is mandated to participate at Kaiser in this, but we would expect that you would refer if you're not able to. Michelle, anything else?
I would just add into the providers who are not comfortable. Please don't tell your patients, we don't do this. I get feedback, oh, we don't do this at all in Hawaii. And some patients are quite surprised. So be the professional to listen, to be non-judgmental, even if it it's against your beliefs and your rules and stuff, just be knowing, putting yourself where this patient is at and seeking the right resources, right? So be aware of your response, just quick responses, because that's really puts off patients. And then that's why they're scared. They're scared of talking with their doctors, right? So please, and then again, if you're uncomfortable, reach out to those who have done this and ask questions. Thank you. Next one.
So this is, this question actually came up with some community health providers when we were doing a presentation. So we thought it would be good to share this with you. But so when does this conversation take place? Obviously being prepared to talk about it, number one, but again, earlier the better. So obviously, this is a difficult, it can be a difficult conversation. So one would need to have some rapport with this patient and have an established relationship. During advanced care planning discussion, great time to talk about various end-of-life options. Patient relays concerns or has wishes for end-of-life care, or patient has questions related to end-of-life. All a really good time to talk about, again, all of the options, MAID included. And then how, you're really asking the patient, what are they aware of in terms of end-of-life options? And you'd be surprised at the number of patients in Hawaii that don't know about medical aid in dying law. And then asking permission to share information, and again, being prepared so that you're able to speak to the law and understand it and all the requirements. Michelle, anything there?
No.
Good.
Pretty good.
Thank you, Susan and Michelle, for all that information. We're going to transition now to Dr. Grote to talk a little bit more about, not yet.
Oh, one more. Yeah. So I'm sure as nurses, physicians, social workers, you're all aware of this, right? Active listening. It's always interesting. I think, especially as nurses, we underestimate the therapeutic effect of listening, and really listening to understand, as opposed to listening and thinking about how you're going to respond, which is easy to do, right? But really trying to understand, asking open-ended questions so you really get a litany of information from this patient, paying attention to nonverbal cues, and then really periodically reflecting with paraphrasing, right? So what I think I'm hearing you saying is this, right? So again, just some really good techniques that can be used obviously in any setting, but especially in this setting where you really want to understand the patient's thoughts and fears and wishes. Okay, I think we're ready for transition now.
I think so. Sorry about that. So Dr. Grote, if you can help us with how medical aid in dying really fits in with the bigger picture of options.
Absolutely. Thank you, Susan and Michelle. That was great. So medical aid in dying is one of many options for patients at the end of life. Some elect to continue to pursue life-sustaining and aggressive treatment up until the time of death, and others decide as a disease progresses or the symptom burden or treatment burden becomes too great to stop treatment. Palliative care is an interdisciplinary team that focuses on improving quality of life in patients and their families who have a serious life-limiting illness. It works to relieve pain and symptoms. It looks to provide emotional and spiritual support, and also explores the values and goals that a patient may have and ensure that the treatment and the medical care that they're receiving is congruent with that. As part of the interdisciplinary team, we have not only clinicians like physicians, nurse practitioners, and nurses, but also social workers, spiritual care providers such as chaplains, child life specialists. Hospice care is under the umbrella of palliative care. And unlike palliative care, which can be accessed at any time during a person's trajectory with a serious illness. Hospice care is particularly for patients in the last 6 months of life. These patients at the time of hospice enrollment usually decide that they no longer want any type of aggressive treatment, and they then will come on to hospice care. Continuous deep sedation is used in patients who have a significant symptom burden that we have been unable to relieve with aggressive treatments that we have tried. Frequently, symptoms will be things like shortness of breath, unrelieved pain, agitation or delirium near the end of life. And this is an option that we use when a patient only has weeks to live. It's usually done with benzodiazepine, so a very sedating medication that we will give either sublingually or subcutaneously. And the goal of this is to place patients into a very deep coma where they're no longer aware for the remainder of their dying process. While they're receiving this sedation, we continue to provide excellent pain management and continue to monitor them closely for any other signs of symptoms or distress, which we can medicate as appropriately. This is a process where a patient may be alive for days, sometimes a week afterwards. So providing support to family members, training them on caring for a patient who is in a deep comatose state is a big part of helping out a patient who is getting this treatment. Voluntary stopping of eating and drinking is a process where a patient voluntarily refuses any food or drink, knowing that this will result in their death. Unlike medical aid in dying, it is legal in all 50 states. And unlike medical dying, it does not require the process of an attending physician, a mental health care evaluation. This is something that a patient can decide to do on their own and does not necessarily need any interaction within the medical community. Also, with this option, there is no need for a 6-month prognosis. Now, I say that there's no need for interventions from the medical community, but it is highly advisable to either have the primary care physician, a palliative care team, or a hospice team assisting a patient and supporting the patient and the family during this process. It often requires, again, a lot of teaching, as well as medications that can help make a patient more comfortable through this process. Usually within the first 2 to 3 days of stopping eating and drinking, a patient will still be up, alert, able to get around, but as they become more dehydrated, they will slowly become bedbound. And again, this can require a lot of training and support for family members. It usually takes anywhere from 1 to 2 weeks for a person to pass away when they do stop eating and drinking. And again, having the support from an interdisciplinary team can be very helpful for family members as their loved ones go through this process. And then, of course, there's the medical aid in dying option. Next slide, please. So we spoke a bit about hospice being under the umbrella of palliative care, and our philosophy is that every person is entitled to comfort, support, and control over how and where they live out end of life. In the community, there is often this misconception that hospice happens at a place, but hospice actually will come out to a home, a nursing home, wherever it is that a patient is residing. Medicare hospice criteria require that a patient has a prognosis of 6 months or less. And the majority of our patients will either have a end-stage cancer diagnosis or end-stage heart or lung disease, and a fair number will also have dementia. There are some patients that don't necessarily fit into this group very easily. And as long as there are 2 physicians that feel that this patient has a prognosis of 6 months or less, then they are eligible to receive hospice care. Next slide, please. I think one of the benefits of palliative care and hospice is the fact that patients are families are really the center of our focus. Again, I can't stress enough about the importance of the interdisciplinary team. Our chaplains and social workers are so important in helping to provide support to patients and their families as they're going through this. I think another important thing about hospice is we focus a little bit on the illness, but there's also a huge focus on the desires and the goals of the patient as they're living their end of life journey. We want to know any unfinished business that they have, any goals that they have, and figure out ways that we can help support them in getting those things done. Next slide, please. Another benefit of palliative and hospice care is this concept of total pain. Total pain was coined by Dame Celia Saunders in her work with patients at near end of life. As clinicians, we often think of pain as either actual or potential tissue damage, sending signals to the brain that we read as pain. But what she found in her work with these patients is that patients perceive pain not only because of the physical stimulation, but also because of past experiences that they have had, how they have been raised culturally, their expectations for the future and what that might look like for them. So we are having pain that also affects us socially, spiritually, and psychologically. You know, as you are given a terminal diagnosis, it is a life-changing event. Suddenly, our roles within the family change, our ability to work and be financial breadwinners changes. Our relationships with God can change. Why is this happening to me? Why did this happen to me? Was there something I did wrong? And having a chaplain who is able to intervene and counsel is extremely helpful. The psychological effects as a person works to wrap their minds around the fact that they are passing away are huge. The grief reaction, depression, anxiety. And again, while we can give medications for this, sometimes just having someone who is able to listen and counsel them effectively, like social workers are able to do, can be very, very helpful. I think Celia Saunders realized that as clinicians, we tend to focus on the physical part of pain. And if we do this, we run the risk of over-medicating patients and inadequately treating their pain. And in order to really understand a patient's pain, it requires time, which is something that in the outpatient setting, we don't always have the luxury of having. But when a patient is on hospice or palliative care, we're often allowed greater visit times, an ability to create that rapport. And with time and the expertise that the interdisciplinary team can bring to patients, I think we're really able to treat pain much more effectively in this setting. Next slide, please. So all hospices treat medical aid in dying differently. At Navien, our process has evolved since the implementation of the law back in 2019. At the time that the law was implemented, we realized the importance of having a team dedicated solely to our care, our choice. And whenever one of our team members hears a patient talking specifically about medical aid in dying or asking about hastening their death, that person will then give our team a call so that we are able to go out and find out more about why a patient is thinking about doing this, much like Susan and Michelle were speaking about, being open, being non-judgmental, figuring out what we may be able to do in addition to starting the medical aid and dying process to help patients deal with some of the pain and the suffering that they are experiencing. Next slide, please. At Navient, we also help to facilitate referrals to the attending MDs and the mental health care evaluation. Much like Michelle spoke about, when attending MDs are first timers or a little uncertain about the process, we offer support so that they're able to feel comfortable in this role. As you can imagine, for both patients and family members, when a patient decides to look into this, there can be a lot of struggle about them doing this and a lot of unresolved issues or worries about it. So we also have early bereavement available. And we also offer to be available to support patients and families at the time of ingestion. It can be a pretty scary time, and there are changes that occur in a patient as they go through the dying process, and sometimes having staff there who are able to explain it and reassure them that it's a normal part of the dying process is something that families really need and appreciate in the end. Next slide, please. So I wanted to share a bit about a patient who we had. We'll call her Debbie. She was a 77-year-old woman who was diagnosed with metastatic lung cancer in July of 2024. At the time of diagnosis, she already had metastases to the liver, to multiple bones, including her ribs, spine, pelvis, and femur. She underwent both chemotherapy and radiation therapy, and unfortunately, despite that, had progressive disease. So she came on to our hospice service in December of this past year. Her comorbidities included end-stage COPD. She was on continuous oxygen at 3.5 liters. She also had some obesity, some osteoarthritis of her knees and hips. So her ability to get around and move was definitely a challenge for her. The nurse who was working with her let me know that she had asked her about ending things a little more quickly. So I went in to see her and see how she was doing. One of her biggest complaints was pain. And in fact, 3 months prior to her diagnosis, she had had multiple trips to the ER for chest and hip pain. At that time, the workup had been negative. She had been started on some oxycodone as an outpatient, which had not been so effective. When I saw her, she was having significant pain despite being on a long-acting morphine and having access to oxycodone kind of on an as-needed basis. The problem was that when she took the oxycodone, she found herself very sedated. And for her, the ability to be up and to interact was very important to her. She had 2 children, a daughter who lived in California and a son who lived here on island. But she was, like I said, fiercely independent. She lived alone. Well, actually, she did have a cat. She lived alone and she didn't want to be a burden on her family. She really worried that she was taking time away from them and their jobs and their families. And despite them wanting to be there more for her, despite them wanting to spend the night with her to make sure that she was safe, she consistently refused. So part of her desire for pursuing this option was really not wanting to be a burden to her family, not wanting to end up sedated on drugs, spending her day in bed. And because of this, we started the process. She had been a Kaiser patient, and it's always so helpful as a hospice to be able to reach out to an organization that either has some kind of navigator role in place, because I could reach out to Jody over at Kaiser, let her know that this patient was interested in medical aid in dying, and within a week, we were able to get the attending physician and the mental health care evaluation done, and I was able to fulfill the consulting role. She was working on the written request during this time, and we were continuing to need to make adjustments to her pain medication. But this was confounded again by the fact that she did not want to have any long time help in the house. Her kids could come over for an hour or two, and then she would tell them that she was ready for them to go. Our social worker went in and tried to give her resources for private hire so that she could have non-family members come in and take care of her. But again, she just wanted to be in her home on her own. She ended up going to the ER eventually because of poorly managed pain. And when she was in the ER, was able to receive some IV medications, which were helpful for her, but was found to be pretty weak. And her ability to be able to safely be discharged home at that time was not really an option. Her daughter was on her way over from California when that ER admission happened, and the plan then became to admit her to our Kailua home, where she could have some 24-hour care with the possibility of going home with her family after her daughter came here. Once we got her to the Kailua home, we started her on a morphine PCA, and we were able to get her pain fairly well managed. At that time, her daughter had come in, but patient continued to say she didn't want her daughter, or really her son, being there taking care of her. With our Kailua House staff, she was very agreeable to having care given and was extraordinarily appreciative of that care, very gracious. She was worried about her cat. That was one worry that she had. And over the 3 weeks that she was at the Kailua home, she was able to work with her daughter to get her cat adopted. And over this time, probably until about the last week, she was still able to get up with Max Assist, sit in a wheelchair, and enjoy her surroundings. It was pretty telling that on the night before she died, she could tell within herself that something was wrong because it was the first night that she ever asked her daughter to stay with her overnight. And it was early the next morning when she took her final breath. So a case where having the option for medical aid in dying and having the autonomy to be able to say, if I get up to this point, I want to be able to exit. But with the support of the care team and with her family, she was able to pass away as she wanted, even without the medication. Next slide.
Thank you, Emma. Susan, you want to talk about the hospice involvement?
Sure. So I spoke with the 11 hospices, and actually 4 of them shared their policy with me, which thank you very much for that. And I just want to say that I suspect that a lot of your policies were written soon after the law was enacted in 2019. So I would just urge you to review the policy, consider if there's any updates that are needed, and that I think nurses can play a really vital role in policy, especially with medical aid in dying. So let's just take a look. So if we take a look at the 11, one of the hospices, the staff acts as the attending provider. One of the hospices allow the staff to mix the medication. 6 of the hospices have staff present at bedside when it's self-administration, and then 3 of the hospices have staff acting as consultant. So you get a sense of kind of where we're at in terms of their involvement. And then note at the bottom, none of the hospices initiate this discussion. And I think as Dr. Grote mentioned, whether they actually bring up medical aid in dying or they bring up their interest in hastening death, it sounds like Navi and then conversation then ensues. I just want to really quickly share this quote with you because I think it's really important. And this was an article written on hospice care, and this was from the Journal of Aid in Dying Medicine. And I'm going to quote, "Institutional policy requiring nurses to leave the room during the ingestion of aid in dying medications is ethically unsupportable because it risks violating professional nursing standards." So just a little bit of my pet peeve in there. Just want to throw that out to you, but something to think about in terms of being at the bedside. And I think that's it on that slide.
Michelle, can you tell us a story from your perspective?
Yeah, can you go to the next slide? Thank you.
Sure.
So I had we had an 80-year-old patient. She had interstitial lung disease. She was hospitalized and she got discharged. And she was a medical healthcare professional. And she got discharged to a foster care home with home oxygen at 3 liters. And she was very sure she knew all the end of life options. You know, healthcare professionals, we think we knew it all, and this is what she wanted. She says, I don't want to suffer. I'm having a hard time. I'm short of breath. This is not the life I want to live. And so I didn't have an oncology social worker. So I did go up and I meet her, and I did bring one of an end of life doula with me, because just by talking to her, I could tell she had a lot of anxiety. I got referred from her PCP, who was willing to be her attending provider. So when we met with her, basically, why MAID? I'd already told you, short of breath. What was important to her? Her grandchildren. Her grandchildren were her life. And what was her fears? Oh my gosh, I don't know if my grandchildren know I'm dying. Her 2 grandchildren are in their late teens, and that was her biggest worry. What brings her joy? Her children, her daughters, and her grandchildren. But her greatest joy was honestly her grandchildren. And her fear was like, I don't know if I'm going to tell them about medical aid and dying, that I want this. Long story short, spiritual religious, not religious, but more spiritually, to be, was she at peace? No, I met her in February of last year, and I was like, why are you not at peace? Because I'm scared for my grandchildren. So I said, woman, I didn't say it like that, but you've got work to do. So that was her homework. And she was already enrolled with hospice. And with the hospice service, oh my gosh, I can't thank them enough, because social worker was there, nurse was there, and the bereavement counselor. Early, like Emma said, early bereavement. Why? Because she needed that support to work with her children, her grandchildren also, because you know what happens when your mom, your parent is going through crisis. Sometimes the children don't always agree. So there are disagreements. So we have to work that complex issue and with the grandchildren. And I can't thank you enough for that hospice team that was there for her. And they recognize that. The same with the end of life doula. She says, I will be there. We don't want the children to have, not the children, her immediate children to have any, because they're already, we're anxious. The daughter met us there. So we'll take that out of your plate. But I'm going to go straight to the end, because before they were able, before she passed and she did take the medication, she basically couldn't do it in a foster care home. She went to the home, and her children was there because of the team, the hospice team, and the grandchildren. They got them to talk and discuss. And not only that, also recognize we needed another end-of-life doula who was a child life expert therapist. So with that combination, everything, that weekend that she spent was her greatest joy. Her daughters were at peace. They said their goodbyes to her. The grandchildren were present. They were aware that grandma was going to take this medication. The grandson made her playlist of her favorite music. The poster was done of all of her favorite pictures. And it was peace. I was not present, but the relay I got, and we did a debriefing after with the team, and it was such a peace, because her most important wishes, her joys, was her grandchildren, her immediate children. And that's what a mother wants, honestly. And she could pass peacefully. Her wish was to see her granddaughter's graduation in May and her grandson's birthday in June. And so she passed at the end of June. So 4 months, very peaceful. So kudos to the team, the end of life doulas, hooray, and the hospice team, hooray. So, and the providers who helped in supporting her. Next slide. Inpatient, at HPH, it's prohibited right now. But we do encourage palliative care support. Our social workers have all been educated on this and started education. They'll give me a heads up, hey, we're going to get this patient discharged, and then we'll start the process rolling once the patient is anticipating the discharge. So we do a handoff. The social workers do all the navigation through it, and then the handoff to, if it's whichever team will take care of it, and then we'll follow the patient through from there. I believe at Kaiser, Susan, can you talk about KP process, because it's not prohibited at Kaiser?
So I know at Kaiser, they will often start education while the patient's in the hospital, and there have been some situations where the attending provider does the initial evaluation. So again, not common, but in some cases allowed.
Right. Next slide. Thanks, Susan.
Hmm?
I spoke a lot about end-of-life doula. I would recommend an end-of-life doula for patients. And I usually don't even tell the patient that you should mix your own medication. I say, who's your support person? Because I want you to be comfortable at your day. This is your day, and get somebody else to do it for you. If they're not comfortable, that's when I'll do an end-of-life doula. If I find the families are anxious, take it out from their hands. And then, as I said, I've utilized more than one end-of-life doula. Outer Island as well, and they're there 24/7 doing all their to-do lists, their wish lists, great stories, but I don't have time to tell you that. But and just I can't tell you how much it means to be. I can relax because I'm not present there, and I can rely on those end of the to make sure things are done comfortably and correctly. So legislate projects, etc. So yay. And we're getting more. So next slide. Thanks to that group, we have this was a request from one of my patients. Michelle, I know the hospice staff is great, but guess what? My spouse took the medication, and it's different discussion with that hospice group, and when their loved one died unexpectedly or from a chronic illness or so. So thanks to Leilani, yay Leilani, and Joy Rodriguez, who is one of the end-of-life doulas. They started a bereavement group. I think it's been over a year, and it's a Zoom, and it's for obviously the families. And even if like Emma's patient, their family can attend that, even if they did not take medical aid in dying. And for my patient that took it, he was like, oh, this is just exactly what I needed. And it's free. Next slide.
We're going to do a quick update on the numbers. So what medical aid in dying has looked like across the state over the last 5 years. So this just shares with you, this is the information from the Department of Health. So they just finished their 2024 report, right? Literally like a couple of days ago. So we were able to get these numbers. But as you can see, obviously half of year for 2019, slow growth around and acceptance around this as a end-of-life option. We will continue to always monitor these numbers, help out where we can. One of the things that I think is helpful is to start to take a look at how many new providers each year are helping with medical aid in dying. We know that it's definitely as much of a process to the professional as it is to the family and the patient. And so it's just helpful for us to use numbers like these and kind of monitor what's going on. We also have some Hawaii Pacific Health and Kaiser data. Michelle, can you talk a little bit about these numbers?
So this is KP does their own data, and I do the data for HPH. So this is our combined totals. So referrals are patient inquiries. We're doing the education, the process, etc. And then out of those patients, how many actually went ahead with the process and got their medication? 257, and of those 150. So you can see percentage-wise, that's about average when you compare it to the mainland as well. Next slide. this is me. I collect the data. So this is for the last from 19 to last year, 2012-31. You could see in terms of ethnicity, 56% white Caucasian, followed by Asian, and then Native Hawaiian, Pacific Island, but 9%. We do obviously Oahu, Kauai. We have our Wilcox Medical Center, but our oncologists do go outer islands. So and then you could see this cancer diagnosis of all of our medical aided was 82%. And that's also very similar numbers to Kaiser and to the mainland. Next slide. In terms of demographics, medical aided dying is legal over 18. We did had an 18-year-old inquired, died naturally without taking the medication, but wanted to start the process. But you could see the bulk of it is between the 16 to 80-year-old population. And then male to female, male was 54% out of 192 patients. Next slide.
Susan?
So just, again, just in light of having time for questions, similar to HBH, majority of the diagnosis are cancer. Yeah, next slide, just so we can move along. Yeah. So just really quickly, liability wise, there's no duty to participate. There's no liability for medical team if they're acting in good faith. There's been no disciplinary action taken against the license by any of the state boards participating or declining to participate. Under Hawaii law, patients cannot be denied health or life insurance by participating in MAID. Again, death certificates, the terminal disease, again, not considered suicide. Next slide.
Okay, Sam, can you help us launch our post-test polling questions?
Sure. I didn't know you were going to ask me right now. Here you go. Can you see them?
Oh, these are the pre-test. There should be a post-test one too.
Oh, yeah. Here we go. Oh, it just disappeared.
So everyone, you can take a little bit of time to read and give us your post-test answers on these questions now. That would be great.
Gosh.
And you should all know the answers now because we give you a beautiful, thorough education on it.
I can tell already you're doing much better. All right, we have about half of the people have responded. We'll wait another minute.
I think, Sam, we had 119 responded for the pre-test. So if we can get at least the equal amount, that'd be great. So keep answering those questions. We need it for your CEs, okay?
Yes. Yeah. Exactly.
In the meantime, I've started answering some of the questions in the chat.
Okay, that's great.
Yeah, so if you have asked a question in the chat, please make sure and go back and look for your answer. We know that we won't have time to get to all of these verbally.
We'll include them though we'll send out the PowerPoint presentation as well as then the answers to the questions. So that'll be great.
You can email the resources too. I see your question, Kathleen.
Great.
All right, we have 108 people have responded. Can we get 10 more?
It kind of slowed down. So let's get to the questions.
Okay, well, I'm going to end the poll.
And the poll.
Yeah, I know some people for instance, the team from Queens had to leave for a 1 o'clock Zoom, so.
Sure. All right, so let's
So
so
can you
now let's
provide the
go
answers?
go through the answers. So Susan and Michelle, the provider can administer the medication upon the patient's request. True or false?
Go ahead,
False.
Susan.
False.
Okay, can you tell a little bit about that?
I mean, by law, it's got to be self-administered.
Yep, exactly.
Patient-driven.
Patient-driven, yep. The mental health provider evaluation is not required for medical aid in dying.
It is required in the state of Hawaii.
Yep.
So false.
Once the
Mhm.
Department of Health receives the forms, the healthcare team will be notified to proceed with medical aid in dying.
And this was my oversight. I'm sorry, I did not answer this question. Therefore, it is false. So so the providers evaluate the patient. The forms are collated along with the written request. They're submitted. That's it. Department of Health has nothing to do with the actual process. They collate those forms. So I take my error on this one.
The
I was
forms are only once a prescription is written and when a patient expires, with or without
Yes.
medical aid and dying medication.
At the end
Yeah.
of the process.
Yeah,
Yeah,
there's
correct.
there's 2 points where you're submitting forms. So I did not answer that question nicely for you all.
Medical aid in dying patients are not required to be under hospice care.
True, right? So strongly recommended, but not required.
Awesome. Thank you. Thank you, everyone, for participating. Susan, the
Yeah, so I'm
HPA.
gonna go really quickly over the next couple of slides because I actually want to get to the resources.
Mhm.
So Hospice and Palliative Nurse Association have a statement. You can read it, pretty clear. What's nice to see is they advocate for organizational transparency to patients and families upon admission regarding whether MAID can be implemented for all the patients in their care. And next slide is the ANA, American Nurses Association. Again, what we keep saying over and over is being objective, being knowledgeable, being aware of your own personal values, being value neutral in terms of discussions, and then never abandon or refuse to provide comfort and safety measures if they choose MAID. The next slide has got some resources, and I just want to go into a little bit of detail on, so Hawaii Department of Health, you're going to see there's all the forms are there. There's a timeline, the eligibility process, information for obtaining a DEA license. What I want to mention is the Academy of Aid in Dying Medicine, which used to be called American Clinicians Academy on MAID, for those of you that might be familiar with this, but a great resource. It has courses. It has a section for patient and families. There's a section for hospices on policy guidance, staff materials, and resources. There's a clinician hotline. There's a handout that's really nice on red flags for possible prolonged deaths. They also produce a journal. So that quote that I gave you around being at the bedside, that came from the Journal of Aid in Dying Medicine on this website, December 2023. There's 2 articles that are excellent. The one that I quoted from, it's Hospice Policies on MAID, Current Practices and Recent Progress. You'll see that quote, and it is along with other information. The other article that's really good is Assisted Suicide Funding Restriction Act, Pathway to Compliance for Hospices. Both are really informative. And if I can just add that one of the hospices that I spoke with or that shared their policy with me, they equated MAID with physician-assisted suicide. So again, that's why I'm just saying, please look at your policies and look for possible updates that are required. Just wanted to get that in there. I know we don't have a lot of time for questions, but a few minutes.
And just how to find Hawaii end-of-life options. We have a voicemail, we have a website or an email address, and we're really all about patient education and patient support, provider education and support, and working with the hospices and healthcare organizations to incorporate MAID-related services. So we're excited to be around and to be here to help as we move forward. So yes, questions and answers. Sam and Aubrey, do you have a couple of questions out there that we could take a look at?
Sure. I mean, literally, we have had some incredible questions. Thank you all. I mean, really, really thoughtful, good questions. We have almost 20 different separate questions, and we will not have time to get to all of them, but we will compile those answers for everyone and get that back to you.
And by the way, people will get a copy of the recording as well. So we'll do the questions with that too. Great, thanks. Go ahead.
So I'm going to try to go through some of these really quickly.
Mhm.
Question, can you be the care coordinator and also be the provider with a MAID patient? And the answer is yes. Thank you.
Absolutely.
What kind of accommodations can be made for a person with ALS? So it's still considered self-administration. Dr. Grote, do you want to, or does anyone, Susan, Michelle?
And they also asked, would the patient have to cover the cost? They were wondering
Yeah.
about.
So we're talking about like a feeding tube or a rectal plunger, that kind of thing.
So
So
the
I can
time
say,
short.
go ahead, Dr. Grote.
So the time period is limited in which they can ingest the medication. And when we're going in and doing counseling, we will usually let patients know the limitations with being able to drink the medication, also with having the mental capacity to choose to do the medication as well.
Right, can that patient tip their head over and suck on that straw? Do they have the ability to do that? In terms of supplies at Kaiser, that's within that bundle of copay of $0 to $270. There's no additional cost for the plunger and the tubing and whatnot.
I have a question for our moderator. So we are at 1:30 right now. Can we keep going for those who want to stay, or do we have to stop?
I think we
Keep going. Okay. Okay. So there was a question about in the instance of really high opioid usage and then being eligible for MAID. Michelle, can you?
Yes, we had a patient who had high opioid usage, and he was actually metastatic cancer, but he lived longer than 6 months, up to a year actually. But he worked out a lot. He had a podcast, you can actually Google it, but he needed a higher dose medication just because of the high dose. So we went up on the phenobarbital. And again, looked at the research from the academy. I call it ACMAID, but now it's changed. And I looked up the research. So we were able to do an increase of the phenobarbital dosage, and he died.
Bottom line
peacefully.
is yes, still eligible as long as they have
Yes.
capacity. Someone asked for a list of the pharmacies. The medical aid in dying medication requires a compounding pharmacy, so you can't just walk into CVS. We generally are using ElixRx based in Oahu, and they will FedEx anywhere on the island to any patient or designated recipient proxy. I believe there are a handful, like maybe 1, 2, 3 other compounding pharmacies in the state that we have not really heard, whether they'll do this or not. Data on whether insurance is reimbursing those who pay directly.
We don't have any data.
We're shaking our head. We know that some will. It depends on the insurance. I've heard from one of our providers that they maybe helped a patient get that reimbursement. Quest covers it, but it's really case by case. Let's see. Oh, this is a good question. Maybe Michelle or Susan. The pronouncement of death, the pronouncement and the death certificate process, who handles that if the patient is not enrolled in hospice?
I can speak to Kaiser. So often the attending provider, such as Dr. Miller, will actually, if he's not on site, he will go to the patient's home and he will pronounce and he will complete the paperwork as needed.
For all of our patients at HBH, they've been enrolled in hospice. And so it's a hospice team, the provider, like Dr. Gross would do it. And if it's not, but we haven't had that, it'll be their attending provider.
I can tell you anecdotally on the neighbor islands, especially, we don't have medical examiners. I'm calling in from Volcano, Hawaii. So it then ends up requiring the police to be called. And that is not generally how a family or a patient wants things to go. So that is one of the many reasons that we always highly encourage hospice enrollment, even just for the time of death. This is a great question for any of our practitioners. What is the protocol, if any, for a patient who begins ingestion and then refuses or is unable to finish drinking the medication? Understandably, this could put the family or anyone attending that death in a really difficult position. I mean, this is something that, you know, conceivably can or does come up, albeit very rarely. So, I mean, is that, how would that be handled?
Respecting patient autonomy, and if they decide they do not want to go through with it, then watching, waiting, seeing what happens. We have had a patient who was only able to take in about half of the medication before she actually went to sleep. And it took her a little bit longer, but she did eventually end up passing away about 5 hours later. Most of our patients, when all the patients that we have on this are signing a post prior to taking it, so that even if they have not been able to take all of the medication, taking them to the ER and doing anything to try and reverse the medication is not something that we would try and do. We have had patients in the past that we worry about prolonged time until death. And is this patient going to wake up? Is it not working? So having something like lorazepam and then going with the plan of putting them into a deep palliative sedation so that they never wake up after starting the medication is something that we would go to for plan B.
Thank you. This is for all three of our providers. How are your different programs or agencies, facilities deal with providers who are willing to participate versus providers who are not within your organization? Michelle, why don't you start?
Yeah, I kind of mentioned this before. The ones who are willing to participate, and my name is all out there. I will do the education with them one-on-one. And so to walk them through the process. And if they're not comfortable, I always tell them, don't hesitate to say, I'm uncomfortable, because I don't want you to start a process that you're in your heart and soul, you're not comfortable with. So then we'll figure out another provider that can help and support the patient foremost. Yeah. Susan? Anything?
Yeah, so Kaiser's fortunate to have obviously a number of providers that are willing to be MAID providers. And then I believe the navigators actually keep a list of those that are not interested. So, you know, they don't continually ask them. So again, it's provider's choice, and the navigators obviously respect that.
I have to add to that. I had one provider who was not willing, and it just took a time, 2019, just till new. And then a couple of years, and then it was like, yeah, I'm willing now. So yeah, go back to the table.
Yes.
Yeah, good point. Thank you. Does anyone have experience with patients who are interested in medical aid in dying but don't have access to treatment or face long waiting lists? You know, I can say, I mean, obviously, if our three providers are working with these patients, then they have access to treatment. They're already in your system. I definitely, part of what Hawaii End of Life Options and I and Susan do is help people who don't have access to medical aid in dying, who aren't able to find it from their current care team or find it on their own. I personally have not come across anyone who wants medical aid in dying simply because they cannot afford chemotherapy or they don't have access to curative treatment. We do have patients who opt not to pursue more curative treatment. And of course, medical aid in dying is their legal option. So I hope that answers that question.
And just really quickly, the insurance companies are not allowed to deny a person life-saving treatment because of medical aid in dying. So insurance companies cannot push a person into aid in dying. That's illegal.
Thanks, Sam. This was already answered, I believe, but it is important. If the patient is in hospice, will the hospice team, such as the nurse or the social worker, handle the patient navigator role for medical aid in dying? And Dr. Grote, I believe you mentioned, you know, and Susan as well in your research, it depends on the hospice. But the general answer is it's not a given, not necessarily. And that's another area where Hawaii End of Life Options can help you if your patients are interested.
But they will always be there to provide the hospice services, you know, and then we can work alongside with the team.
Finally, what is the protocol for the leftover medication if the patient expires without taking it? Michelle, could you?
Oh yeah, well,
answer?
so there's the take back program at CVS. I know some of the end of life doulas do would dilute it. The medication, do not dispose in a toilet, in our drain system or things like that. But we do follow up if the patient has not. Some hospice will not take back the medication. So every hospice is different if they take back the medical aid and dying medication or not.
In general, you know, it is a deadly medication in just as many bedside medications are for a terminal patient. So that it would be disposed of in the same way. I think we covered all the questions, but again, we'll have answers and put that and make sure that's in what everyone receives.
Just got one last.
Thank you. Oh, sorry, I missed one. Thank you, Sam.
Well, it just came in. So what resources do we give to our patients who are non-Kaiser who need a provider to assist with medical aid and dying? I think that's a good question to end on.
Oh, perfect. Did you just put that one in there? So definitely, please always feel free to refer them to us, to Hawaii End of Life Options. We did have a slide that has our voicemail for people to call direct. And I know that, I mean, I'm recognizing a lot of names, and I've been working with a lot of social workers from hospice, and you know how to reach me directly. And I know some of our clinicians know how to reach Karen directly. Everyone's always welcome to do that. But if you're just passing out general information, we like to use that hawaiiendoflifeoptions.org for our website. And our phone number is also on there. And then hawaiiendoflifeoptions@gmail.com is our email.
And finally, yes, we will and would love your input on an evaluation for our session today. So thank you everyone for participating. It was wonderful to see so many people interested in this topic. Thank you to all the presenters. You did wonderfully as usual. It was just really, really exciting to pull this together for our new organization, as well as just being able to continue to support the work that's out there that all of you are doing. So on that note, I think we will stop the recording and end our presentation. Michelle, anything else we need to do for the CEUs before we end this?
No, we're all good. Everybody registered. Thank you. And thanks for bearing with us with the links, etc. So I appreciate that.
And presenters, if you have a quick extra 5 minutes, maybe just hang on and we'll end this for everybody else. Okay. Thank you, everyone.
Aloha.
Aloha.